That'll make the difference. Yep. And if you stand that close, it's a little blurring. Give yourself like maybe like 12 inches
Okay.
from that.
Hello, everyone. How are you? I'm Dr. Anita Braylock, and we're going to go on and get started. We have our program today, Navigating Difficult Conversations in Nursing, Strategies for Civil Discourse in Challenging Times. Indeed, these are challenging times. We have a lot going on. It's October 30th, and we're only days away from the election. So make sure that you vote. Now, I have alongside two colleagues, graduates from our program, Dr. Marilyn Douglas, who will just say hi and quickly introduce herself. Then we have Dr. Lonnie Herring, who will introduce himself. And then Dr. Herring has some slides that he's going to go over, introducing us to this topic, and then we're going to open it up for discussion. Dr. Douglas.
Hello, good afternoon. My name is Dr. Marilyn Douglas. I am a proud alumni of UCLA's DNP program, and I'm also a family nurse practitioner, and for about 20-something years. And I am the executive director of advanced practice providers at City of Hope National Medical Center. And so navigating difficult discussions, conversations is certainly part of what I do every day. And thank you for having me. And I look forward to the discussion.
Hello, everyone. Can everyone hear me? All right. My name is Dr. Lonnie Herring, and I am a nurse anesthetist and also a proud Bruin graduate with the cohort of Dr. Douglas here. We just graduated this year in 2024 from the DNP program. So go Bruins. So let's get into it because I know we're already running behind. Let's see if we can get this to do what I want it to do. There you go. All right. So adulting is hard. So I know that my audience, there's a lot of Meccan students, but I don't know who the online audience is. But adulting is hard. So you have to learn how to have these conversations when you get into practice. And these conversations can manifest in a variety of ways. It could be conversations regarding patients, difficult patients, with your colleagues, with your superiors, and with the people who are under you. So there's going to be a myriad of different conversations that you might have to navigate. And so you need to be able to take those skills and apply them. And also they transfer over into your private life as well. So understanding the importance of civil discourse is what we're talking about in its current situation, current times, political climate, strategies for effective communication and implications of those conversations within the current global and cultural political climate. We good? All right, so what is civil discourse? So it's a little bit tricky, and you can't really find a clear definition. Everybody has their own definition, but it's a learned behavior. It's a skill that you carry forward of respectful and constructive ways to discuss and exchange ideas and issues. What we also get confused about with it is that sometimes you say, well, that's not civil discourse, but you lose within it just calling out the discourse, but you lose the issues that are actually being addressed. So again, you lose the message, you lose your message in the tone or its delivery. So we've all heard that before. So it's how you deliver it is just as important as what you're delivering or what you're trying to convey. So there's civility, and we talk about there are two types of civility. There's superficial civility where you're just smiling and you're just saying, hey, yes, nice. But there's actual civility where you're actually paying attention to what that person is trying to say. You're interested in what they're trying to say. You're trying to convey your part. They're trying to convey their part. And you're actually trying to have a meeting of the minds at that time. This is what we need to have in our professional and academic settings. And again, it's a lifelong skill set. It's something that we can carry forward and in our private lives as well. That's how I've learned to do it, to have these discussions with my mom, with my parents, with my family members, because We all know that family members, no one can annoy you more than your family members. They know how to push those buttons. So you have to learn how to navigate those conversations with them rather than just screaming and hollering at each other. Again, where it's important is the social determinants of health. We've all heard of those things, is these factors that come into play when we're dealing with patients, when we're dealing with colleagues, when we're dealing with anyone, basically. Where are they coming from? What is their background? So those are the things that we have to consider, and it's understanding and its importance in health and how it relates to health. Of course, challenging conversations are, we have that in our current political climate, and it's getting rough. It's really getting rough over the past week or so, as we all know, but we're not going to go into that. But what we're talking about is people are actually less polarized than we actually think. What we have is what's called an effective polarization. I just don't like that side, as opposed to actually being opposed to ideas. Most of us kind of meet in the middle and can agree on some things, whether you're on the left, whether you're on the right, wherever you stand. We all do have some issues where we can agree, but then where it breaks down is just people just say, I just don't like that side. And so then it's just everybody retreats to their corner. The issue is if you get people together and you actually talk, you'll see that manifests out, that they agree on issues. Same with me and my mother. We agree on a lot of issues, but you go back to your respective corners, your respective friends, your respective family, and it's lights out again. So that's what's really contributing to this rancorous environment that's going on. It's just everybody goes back to their respective corners and they do all the things and say all the things. So then how do we engage? Can you hear? Can you hear? Okay. Okay. Feedback. All right, so how do we engage? So introspection. So first you have to look at implicit biases that what do we bring to the situation? These are things that we all have our own biases, whether you try to admit it or not, you do, just because of how you were born, where you were born, who you were born, whether you're a man, you're a woman, Black, white, Asian, whatever. You all have your own biases because it's just how we learn as adults. It's who we are as people. But you have to know that you have those, and you have explicit biases as well. Those are the ones you can moderate a little bit better. But the implicit biases, you really have to know yourself to know which ones to dig deep down and to see which ones you really need to address. Active listening, and that's more than just hearing somebody. That's actually being interested in what they have to say and how they're saying it and how they're receiving those messages. If I'm standing here like this and I'm talking to you, it's vastly different than if I'm standing here with open arms. So you have to look at how when you're talking to somebody, what are they saying to you? Are they giving you eye contact? Are they interested in what you have to say? Sometimes they're just not even, it's just not the time. So they're not just going to engage you. So, but these are all the things that you have to take into account when you're talking about how do we engage in these conversations and when. Managing your emotions. That's a big one for a lot of us, myself included. You have to make sure that you're ready to have the conversation and that you're not going to fly off the handle. Because again, nobody can push your buttons like your family, but other people can do it too. So you have to make sure that you're ready to manage your emotions and have that conversation. Emotions run high, especially on certain topics. So you're truly invested, and we all have these things that we're passionate about and that we care about. So sometimes it's necessary to just kind of maybe take a break, come back to it later. Right time, right setting. So you don't want to have this conversation with somebody in an elevator. I'm gonna get you right now because I'm mad right now. So I'm gonna get you in this crowded elevator and we're gonna have this conversation. No, you have to pick a right time, right place. Agree, maybe come to that person and say, hey, all right, let's have a meeting of the minds. When can we sit down and talk about that? But don't let it fester. Don't let these emotions that you have just fester, because they will build up and they will come out in not so nice a manner. You also want to be empathetic. That's a word that we hear, but we don't really use, especially when it's somebody that you really, really disagree with. So it's hard to really be empathetic, but you really have to look at what is their perspective. It's not all about me. What are they actually trying to tell me? It may not be, you have to look through how they're delivering it to you and actually see what they're trying to actually tell you and say, okay, well, I can see that point. But still you didn't have to, address it that way. And stop expecting perfection from people. None of us are perfect. We're never going to have it completely right. Nobody does. So I think that's the other part too. We just all have some humility in the situations. Solutions. Don't just scream about it. Let's work on how are we going to move forward? Where are we going to go forward? What's the solution to this? Or are we just going to stay mad at each other and scream at each other or voice our points to each other? Or are we actually going to move forward? You have to move forward. Nothing happens if you don't move forward. Sometimes they can be short-term, sometimes they can be long-term, but you really have to move forward. And it's okay to disagree, respectfully, but it's okay to disagree. And be polite, and kind, and caring. It's good. Questions, anyone?
Okay, thanks, Dr. Herring. So maybe I'll have Dr. Douglas come over and do we have our first question or our first open for discussion? Or I can start with having Dr. Douglas maybe talk about some of these difficult situations she's had in her workplace.
Oh, I could draw on many. So, I can think about this from multiple perspectives, from the challenges of working as a bedside RN, from the challenges of working as an APRN, as a nurse practitioner, and being sort of in the middle, not medicine, not nursing, but having to navigate the space for both sides. Nurse to nurse. And we're all customers of each other, right? So we all have to serve each other in these spaces. I think I'm going to go with something that happened most recently. I would love your feedback and see how you would address this from the academic and professional spaces, because I think that we have to have a level of emotional intelligence, and we also have to bring forward what we know to be professional practice, best practices, et cetera. There's literature out there to help us handle certain situations. So I'll bring up a recent, within the last month that we had to deal with. It's rather complex. This patient is African-American. She is in her 6th decade of life. She has a sister that she's very close with and has been with her from the moment she stepped into the hospital. She is unfortunately undergoing treatment for a very complex infection that is threatening to take her life. And her sister is really standing guard and making sure that her clinical care is going forward in a way that respects her culture. So the sister means no harm, but what she's doing is she's putting up walls of protection for the patient who is unable to speak for herself without coughing, and she's weak, and et cetera. Nursing has been seeing this as obstructive, aggressive, words being used, aggressive, bullying, mean, angry, talking about the sister. And so what happens is the sister's wall goes up further as she hears these titles and words on the other side of the door. And she's not loud. She's not, she's just stoic. And very specific about when they can come into the room, how they approach the sister, and sometimes unreasonable, most times not. And so what began to happen is this wave of misunderstandings and the patient versus staff. And it started to get to the place where it was actually interrupting care. Nurses didn't want to come into the room. I was not involved until I actually came because the family member asked to see some leadership from different spaces. And when I went and sat with this family for 2 hours, it was all misunderstanding. They don't want her to be seen between 3 and 5. They want that to be a space where she can relax, the patient can relax, not necessarily be a patient. They can talk, they can pray, they can call family, they can get support. So please don't come in between 3 and 5. Those kind of requests. The nurses feel that's obstructive because 3 to 5, you're trying to get your day finished for the next shift coming. You got to hang blood, you got to hang antibiotics. And so this thing is spiraling. And the patient is also clinically worsening. All right. So we have a couple of difficult conversations to have here. The first is, how do we honor sort of the cultural spaces that have been established in the room? The second is the customer service space. The third is the discussion of her clinical status, which I think if it was fully honestly disclosed, may be beneficial in the situation. What is best practice for how to deal with this? Is there a best practice method? And how do you de-escalate and not make it about she will not let us do our job? How do we make this a customer service or an honoring of the patient while still expecting some respect from the family?
We have to absolutely look at it from the perspective that the sister is, first of all, advocating and protecting not only her sister, but a very vulnerable population. And as a nurse, like, we need to come to every single bedside with that same respect.
So absolutely, advocating is absolutely part of this, that the sister is in her mind, and she is advocating for her very ill sister that's in, absolutely, yeah, absolutely right. Anyone else, anyone online?
Hold on, you're gonna have to repeat it. I couldn't hear you on. I was just saying, you mentioned the sister came in with her like walls up high, like very strongly trying to be an advocate for her family member. And I feel as a healthcare provider, you have to kind of like establish rapport with them first, like really thinking, is this unreasonable? Can we schedule things before or after? Instead of like, what's most convenient for me? You have to think about your patient. They don't want to be there. It's the worst time of their life, most likely. And like, you have to like set up the schedule for the day with them and the family and being respectful of their time. Like, they need to heal and like they need to de-stress, and the hospital environment is very stressful, very loud. Everybody's coming in, everybody has something to do at every hour.
Something that I continuously think about as I'm providing care, whether that be like at the bedside as a nurse or as a nurse practitioner, especially when I encounter vulnerable populations, I keep in the back of my mind that, there's a lot of stereotypes and biases that are constantly put on these communities. One that drives me nuts, and I argue with my coworkers about sometimes, is that historically Black women are seen as like being irate. And so one of the examples that I use with my coworkers when I have this argument is the tennis players, Serena and Venus Williams. One of them ended up with a blood clot like ×2 with both of her pregnancies. And that even one of the wealthiest Black women in the entire universe can go to a hospital and be completely disregarded about something that she's experienced before. And if it can happen to her, then you better believe it can happen to any Black woman that walks into our healthcare institutions. And come on, like, can we please be aware that every single person of color that is walking this planet, or at least in the United States I can speak to, experiences racism every single day?
A couple of key points that reinforce actually what was in the slide presentation. Empathy. She spoke to empathy. Active listening. Hearing what the sister is really saying, understanding it, and even framing the day around what you heard. She said planning the day out. Very important. Those implicit or not biases, right? All of that is a part of this situation. It's rather complex. Are you about to, another comment? So I wanted to ask, is there, what is your solution here? So I've listened, I'm empathetic, I've listened, I understand that there are biases. Patient's still going to be in that bed. It's going to be a while. It's going to be a long hospitalization. And as this patient gets worse, I can imagine the sister is going to become more anxious. So maybe these behaviors that they feel they're witnessing may even escalate. Is there a solution as nurses? What can we do? And let's also consider how the nurses are feeling, right? We're all customers in this space. What can we do for our colleagues to help them through this? You know, when you hear the colleague go, there she goes being aggressive again, what can we do? That's a difficult conversation that you have to have with your colleague. What can we do as nurses to make this situation better? Any thoughts about that? What kind of conversations can we have? Is it just another module? Right? You know, we're overrun with modules on how to deal with this. All of us are taking them and we're still landing in the same space. So that means that even after the DEI modules and all the mandatory learnings, we have to come all the way down to those discussions, one toward another.
Thank you so much for sharing, and also to our student here sharing. As a nurse practitioner and also a family member who had their father in the ICU, I had to advocate. And it's one of the realities that you have described, and I'm sure it happens quite too frequently. So I've witnessed and I've engaged in different strategies to empower the people that were taking care of my father. And collectively, we worked as a team and we coordinated with the ICU staff. When is the hospitalist or the ICU doctor on duty coming in? We would like to be involved during rounds. And the nurses also advocated. They would text us or call us. Can you please Zoom? We work. My mom has limitations with Zoom, so if you could please help us, we really want to be involved more than you may think. And it takes stakeholder buy-in from the very beginning, because if there's not effective communication and team collaboration from the beginning, it becomes a barrier to try to communicate when all this has occurred, right? So trying to build that trust, the rapport, the advocacy, but as a team, not only the nursing staff, even the phlebotomist. I remember my dad was like, oh my gosh, again, they're gonna poke me at 5 a.m. I want to go to sleep. And then you have RT and like everyone coming in. But I think because if we effectively communicate, and especially not talk over the patient, but involve the patient as well. And we all care about you. We have different disciplines throughout the day. I understand between 3 to 5 is your time. But today our plan is, as you had heard this morning on rounds, that we're going to have, you know, a physical therapist do an evaluation. So what that means is you could either join us so that you can learn the techniques so that we're not there during that time. You can help your sister. And so involvement as well. So it's effective communication, team collaboration, and the willingness to openness. Thank you.
And that was certainly part of the solution.
Sorry, this is totally one of my super passionate areas. But I think what we can always do is lead by example. in addition to everything that you said. I think it's interesting because like some smaller hospitals, some less branded hospitals don't even do safety huddle. They don't even do rounds. So in scenarios and situations like that, like what do you do when rounds and safety huddles and things like that don't occur? And what is it that we can personally do when we don't even have this multidisciplinary team to reach out to? And I think leading by example, some people maybe they don't have the experience engaging with other cultures. So trying to understand the perspective of the nurse that hasn't been so understanding for that patient situation, maybe they haven't been exposed. Maybe the only exposure to that specific community is the blasted image of African American people on television that, is shown, and they don't have any personal experience. So I feel like the best thing that I can do in a situation where I don't have resources, I don't have an IDT team, is lead by example. Lead by example and show people we can engage the same way that you can engage with your own folks.
That we have more in common to that PowerPoint than we think. Like when we get out of our corners and have a conversation, that we have more in common than we think. Absolutely. I just want to say that one of the solutions was to work with her to plan the day every day. Seems so simple. Like, by the way, I would have thought of, why didn't we do this from the beginning? Why are we not doing that just because it's a patient in a bed? But we take for granted that I'm a nurse practitioner, I'm a doctor, I tell you what you're going to do today, hang in there, and that's it. And that's actually what the sister was fighting against. She wanted to be part of the plan, and she wanted it to be shaped around their expectations. And actually things improved greatly after we included this sister in the rounds and telling her when PT is coming, when, et cetera. And then to your point about setting an example, we had one brand new brave nurse manager, small, very petite. You almost think she's like not the manager. She was very young appearing, old soul. She said, she took it and said, I will show you how to do this. We will not use this word. We will describe what we experienced instead of saying aggressive in the chart, right? So let's not use the word aggressive in a chart. Let's say sister asked for this, which describe what it was, because when you start describing, you realize that that word didn't even apply. Was that really aggression, or was that she asked for you to wait 15 more minutes for the pre-med before you gave blood, which was a case, right? Which an example. So she started saying, hey, let's stop using words to describe, a single word to describe what we think the sister was doing. And if she did something to obstruct, let's just document that thing. And there was a reduction in the language, things like that. So yeah, that is an example of how you would need to have these difficult discussions peer-to-peer, patient, physician, as nurses, and we literally do this every day. This was more of an extreme example just for what we're doing now, but you do this every day. And being aware of yourself and reading the room is huge in spaces like this. And just before I step aside, you also have to be able to have that difficult conversation with your leadership. All right. So when I got pulled into it, it was a bit extreme, right? People were highly frustrated. And I said, I wish that you had come to me a little bit sooner so that I can help you with strategy earlier. And they said, we felt uncomfortable saying, that this was happening. You also have to be able to have difficult conversations with those that are leading you, and you have to adapt that conversation, but still represent yourself. Like I said, the nurses also had feelings, and you have to address those feelings, right? So even difficult conversations when you're dealing with your leadership to give you the support and resources, guidance that you need to get through it.
Oh, that's perfect.
Any other thoughts about this? Anyone online?
What about Dr. Herring?
I'm gonna let you step up on side, girl. All right, so what you described, I know you're trying to be nice, but what you're describing is the angry Black woman, ABW. That's what they call it. In our, as a euphemism, we say ABW. ABW. And it's a very common thing. You are absolutely right. It is very, but again, the conversations, I like what you said as far as empowerment. It was clear as day from the beginning. The sister just needs empowerment. She feels helpless. Her sister, who she loves dearly, is in this awful state right now. So you need to help empower not only the patient, but you need to empower her advocate. And you, as the patient advocate, should advocate for the sister, knowing that that's important to her. So that's what you have to do is the empowerment of the situation. How can I empower this sister so that she's involved? She just wants to be involved. And it's like she said, it's a very easy, simple thing that could have been avoided from the very beginning. Simply involve the sister, get her involved in what's going on. You want to know what's going on with your dad. I want to know what's going on with my mom. Anybody wants to know that. And if I don't get that, then yes, I start to get frustrated. I start to lash out. Other things occur. So that's where that manifests. So but again, we also need to learn to have these conversations with our peers as well. So it's not only going to be patient situations, it's going to be doctor to nurse. That's a big one, a huge one, especially when you're in advanced practice. You're going to have to learn to speak up when you know that you're right and stand your ground respectfully, but you have to learn how to stand your ground because you know what you know. He or she may feel that they know what they know, but there needs to be a meeting of the minds. And it's not always just because you have that MD title that I'm going to follow what you say and you get to dictate how my practice goes. So there's a lot of interprofessional collaboration that goes into that. And that's another big place of where these conversations can get a little bit difficult, but you have to learn how to have them. Again, adulting is hard. And now you're on a different level. You know, when you're bedside nursing, BSN, you have to learn to develop those skills. And then when you advance to advanced practice, you really have to step up. You really have to step up, because what's going to happen is if you don't step up, they're just going to step all over you. And then you end up frustrated. And then that's where we lose people in that, because there are a number of APRNs who have gone through these programs and have decided it's too much for me. I can't handle it. I can't make it. Well, you have to learn to develop that skill. It's like parenting. You're here now. The kid is here. You can't give the kid back. Why would you waste that money? Learn to adapt and do what you need to do.
Are there any questions in the chat? No questions yet. So maybe we can change a little focus. I know in your slides, did you mention anything about discourse in an academic setting, especially with everything that's been going on? I know it was, when was it that we had a lot of the demonstrations? That was back last spring, I think on May 1st. We had the demonstrations on campus, and then I know I was listening to some of the podcasts, and they were saying now everybody has anxiety as we get closer to the election, and on a scale of 1 to 10, they were asking people, what's your anxiety level? One lady said hers was up to an 8 or a 9. And so maybe we can talk a little bit about the discourse we may have been seeing. You were a student, you hadn't graduated yet, and you thought maybe you wouldn't even get a graduation, right? Because of everything that was going on. I mean, as far as walking across the stage, because so many graduations were canceled across the country. That's what I'm saying.
Yeah.
So maybe you can talk a little bit about some of this discourse we might have on an academic setting.
Well, so in the academic, I mean, you mean as far as how you have it with,
Well, with everything that's going on right now and everything that's about to happen next week, how are we all feeling? Are we going to feel that we're going to be able to talk about what's going on, or are we going to feel uncomfortable? It's sort of like 2020 with the George Floyd incident. A lot of people didn't want to talk about it. We were going through a pandemic, and all of the civil unrest, all that was happening all at one time. And it was very stressful for people. And now we're coming up on 4 years later and here we are.
Right back at
Right?
it.
Yeah,
Yes, right
yeah.
back at it. Yeah, I mean, it's going to be uncomfortable. You have to learn to sometimes sit in that uncomfortable space and just and learn how to navigate through it. It's not always going to be roses. It's not all, you're not always going to agree. There's always going to be different sides to different things. I think of that whole discourse, I can see both sides of the issue. I see both sides of the coin. But again, you know, people would say, well, you're disinfected. You're not really, doesn't really involve you. You don't really have skin in the game. I do. I care. But you also have to learn to see that there are always two sides to a coin. I'm a Libra, so I always look at two sides of the coin. It's just what I do. It annoys my friends to no end. But you have to learn to see that there's you have to be an adult in the room. Two sides to everything.
Let's just let Dr. Douglas add 5 minutes. Yeah, Dr. Douglas, you want to add something? Thank you, Dr.
Very briefly, the day after the election, you have to work with them. You have to live with them. They will be your family members. They will be your friends.
Coworkers.
They will be your coworkers. And we're very polarized right now, but that active listening and empathy and all of that is going to have to come into play. I was speaking to my son the other day. I said, it's a horrible movie. Don't judge me for watching it, but The Purge.
I love it.
The next day after The Purge, you have to think about the fact that your neighbor was trying to get in your house to purge, right? And for a year, you have to know that they were trying to do something harmful to you until the next. In other words, you cannot keep holding it on them forever. So what do? We have to have some conversations. There's some friends we're going to have conversations with and say, you know, we are very far apart in this space. Can we come together? You're going to have to make decisions. But Wednesday is not going to look like Tuesday. It's probably going to take a lot longer than Wednesday to tabulate. But what I'm saying is there have been posts on Facebook and social media that outrageous. And she said, what on Facebook? He said, what on Facebook? I still have to be your executive director. I still have to be your colleague, even if you said and feel the way that you do. And that's hard, but some of them will require conversation after the election. So keep it in mind. His whole slide presentation has prepared you for Wednesday. You have to be adults in the room after. And how do you do that? And we're not going to do it necessarily well all the time. Sometimes we're going to lose it a little bit, but.
And vote. Vote.
Yeah, absolutely.
And
You
vote.
haven't already voted early. You have.
I just have a question. Juan Espinoza here. So I think for me, the most difficult or most challenging part of having a conversation, especially around the election and the issues of the both sides, how polarized everything is right now, for me is like when engaging with the other side, when the conversation turns illogical and irrational and like that is not truthful. At that point for me, like when I recognize that thought process and that pattern and that speech pattern and the language that's being used, I just withdraw and I just say something like, oh yeah, that's crazy. And like, I just kind of like let the conversation die. That's just like how I do it, because like when the other side is just saying things that are just simply not true, for me, the conversation just becomes toxic. Like it's not even productive anymore. Like it's not a productive interaction. It's not a productive engagement anymore. It's just more about like, I'm gonna tell you whatever outrageous lies I can come up with so that I can make you feel smaller and make you feel like I've won this argument. And I'm more like, well, I mean, but yeah, but what you're saying is not true. I can Google it right now and find out that what you're saying are lies. So that's my issue. And when the conversation does get to that point, it's like a wall or a barrier that I don't know how to break through. And I just kind of dismiss it as I was like, yeah, that's wild, man. And the conversation kind of dies. And I'm like, okay, well, I mean, that may not mean that you're a bad person, but that just means that you have interesting ideas, I guess. So, yeah.
I tell my mom, pull it up on Google.
Yeah.
Prove it. Prove it.
Okay, would anybody else like to add anything? Yes, we have one more comment before she's going to close us out. Thank you.
Back to 2019. And I was living in a different region. Every nurse looked like me. All the CNAs looked like you. And I would go into our break room, which is where we all gathered before we started our safety huddle on the step-down cardiac unit at a regional hospital. And what I found so difficult, and just like Juan said, like, you know, we have these difficult conversations, you get to a point, and then I can think, okay, I agree to disagree, and I still have to work with you, and that's fine. But like something that kind of like hurts me to my soul is, how can you feel this way about human beings and be a nurse? And that really bothers me so deeply. So I want to say that, and I want to know if you all have any guidance. And then I also want to say, what can we do to get more Black nurses?
All human. That's what you have to understand. We're all human. We all have fallibles. We're all fallible. None of us are perfect. And yourself, myself. So you have to allow people to be fallible. That's really what it is.
Excellent point. And recruitment of underrepresented populations like African Americans, pipelining.
Mentoring.
Mentoring is huge. Removing certain things from the applications we found work. De-identifying in a way that you cannot speculate on the race of the candidate. We've actually seen that improve the flow of interviews, which is interesting. So there are strategies. And also promoting, if you can see it, you can be it. So when you don't have, when you're underrepresented on a leadership level, it gets really difficult for someone to believe that they can be that thing. So there are multiple ways that you can improve recruitment, and it's a challenge, but it's doable. Absolutely.
Well, thank you very much, everyone, for joining us. We want to thank Dr. Douglas and Dr. Herring. They did an excellent job. And we'll look forward to the next time we'll be getting together, more than likely after the election, obviously. But I'm not sure if it will be this quarter or not, but Juan will keep you posted as to the next dates for our discussion. So thank you, everyone, and make sure you go vote. Okay, thank you.
Vote.